Hello, good evening. My name is Yinka Oyelese, and I apologize for the delay. I am the director of Obstetric Imaging. I started here in February, and I am very honored to be here. Today, we're going to be talking about soft markers on ultrasound and update. I have the relevant financial or other disclosures. I am very happy to be in Boston. I love fall, and these are some pictures that I took in New Jersey, and I hope that in Boston we will have such a colorful and beautiful fall. So these are from New Jersey last year. Thank you very much. Well, when we talk about screening in ultrasound and we talk about markers, it is important to understand history, because unless we understand the history of how we got here, we will not be able to understand the markers and what we should do with them. So I apologize. I'm going to take about 5 to 10 minutes to talk about the history of Down syndrome as we know it, and then talk about how screening for Down syndrome started. And then we will talk about the markers and the evolution of the markers to the present day. So Down syndrome is named after John Langdon Down, who was a superintendent. He was a physician in London, and he was sent to Surrey, where he was at a place called the Earlswood Asylum for Idiots. Unfortunately, in those days, they were not politically correct. I am glad that man has evolved since then. But unfortunately, what happened was there were people who were noted to have some handicap, and they were put in institutions. And for the first time, Down made some observations about this population of individuals. And unfortunately, his conclusions were not politically correct, but he was the first person to describe what we now know as the phenotype Down syndrome. If his name had been Up, it actually would have been called Up syndrome. So it's named after John Langdon Down. And for several years, this phenotype was known. However, a major advance came when the human karyotype was first discovered by Chio and Levan in 1956. So that was the first time we knew that human beings had 46 chromosomes. And you get half the chromosomes from your mother and half from the father. And then Lejeune in 1958 found out that Down syndrome actually had an extra chromosome 21. He was a French pediatrician and geneticist. Now, why do I talk about these things? Because we assume, unless we understand the history, we assume that these things have always been like this. But remember, this was just a short 65 years ago that Down syndrome was discovered as to be caused by a chromosome 21. And since then, a lot of advances have taken place. But what became very clear was that there was this phenotype called Down syndrome that was associated with such problems as developmental delay, handicap, and so on. And Down syndrome is caused, as we know, by an extra chromosome 21. The only reason we see Down syndrome is because 21 is the smallest chromosome. It's actually smaller than 22. So when they were numbering them, they made a mistake. So when you get an extra one of 2, 3, 4, 5, 6, and 7, and so on, you miscarry. But if you get an extra one of 21, you end up with Down syndrome. So the only way to tell for certain whether a fetus has Down syndrome is invasive testing, whether it be amniocentesis, CVS, or podocentesis. And unfortunately, people think that you have to have an amniocentesis or you don't have to have an amniocentesis. It is a personal decision. But what we do need to realize is that Down syndrome occurs approximately in 1 in 800 births, which means that if you were going to diagnose Down syndrome, so pick up one case, you would do 799 unnecessary procedures. It is expensive, it is invasive, not everybody wants the information. Therefore, it was not possible to do amniocentesis on everybody, to pick up one case and do 799 unnecessary cases. So in the early days, one thing that was known was as you get older, your risk for Down syndrome increases. So this was the first screening test for Down syndrome, that if you were over the age of 35, you would basically be screened positive and be told you were high risk. As I said, Down syndrome is the most common aneuploidy chromosomal disorder, trisomy 21. It is associated with mental handicap, structural and other handicap, and immune dysfunction. But here is a very important slide. Like I said, arbitrarily, the age 35 was chosen, not because 35 is high risk. And I emphasize this because it's extremely important. Very often we see women who are 40 years old and we tell them they are high risk. They are not high risk. What happened at the time was there was no other test. So if you were over 35, you screened positive. But let's look at the data. What actually is the incidence of Down syndrome in these age groups? Well, if you look at term, at the age of 30, the risk of having a baby with Down syndrome is approximately 1 in 1,000. This is a very easy formula to remember. Ask term. It's actually more like 1 in 900, but it doesn't matter. At age 30, 1 in 1,000. At age 40, 1 in 100. At age 35, 1 in 350. So 35 was the first cutoff at which women were offered an amniocentesis. However, when we tell a woman who's 40, yes, she has 10 times the risk of the 30-year-old, but look at the numbers on the other side. At the age of 30, the woman has a 99.9% chance she does not have Down syndrome. At the age of 35, it's 99.7% chance she does not have Down syndrome. And at the age of 40, she has a 99% chance that she does not have a baby with Down syndrome at term. So how then can we tell someone who has a 99% chance that everything is all right, or sorry, that she does not have a baby with Down syndrome, that she is at high risk? However, unfortunately, this paradigm, which is terrible, still remains, and we still use 35 as a cutoff, which I think is incorrect. Actually, most women have a low risk if you look at the 99% chance that the baby doesn't have Down syndrome based on age alone, at least until age 40. Using 35 as an age cutoff misses 2/3 of babies with Down syndrome, and the concept of AMA is inappropriate, at least as a selection for invasive screening. A woman is not 34 years, 11 months, 29 days, 23 hours, 59 minutes, and 59 seconds, and at the time the clock ticks midnight, something terrible happens to her. That only happened once in history in a fairy tale called Cinderella. Now, before I go any further, we must pay tribute to the person without whom we would not be having this discussion, Professor Dr. Beryl Benacerraf, who passed away, I think, about a week and a half ago. She was here in Boston, and she was a legend in ultrasound and in prenatal diagnosis. And actually, she was the first person who described the first ultrasound finding of Down syndrome, which was an increased nuchal fold. And on the right, I don't know whether you can see my mouse, you see the fetal skull, you can see the cerebellum, and at the back of the neck, where you have the white arrow, you can see the nuchal fold, which is increased in thickness. And this was an observation that she found in Down syndrome. Subsequently, Kypros Nicolaides and his group in London found that in the first trimester, the nuchal translucency, which is the skin behind the neck, was also enlarged. Interestingly enough, the first and second trimester nuchal fold and nuchal translucencies are unrelated. So they are independent and unrelated. Now, I want to take a step back because this may make something clear to us. Now, at this time in 1985, when she published the first paper, if you notice what happens here, amniocentesis was used to diagnose Down syndrome in a high-risk group of women, particularly those over 35. So what happened at the time was amniocentesis was done if you were over 35. And for the first time, she described a sonographic sign in babies that had Down syndrome. And what she was saying was, perhaps we should not use 35, but perhaps if you have this finding. Why am I talking about this? Because these soft markers came in an era when there was no screening apart from age. So that is extremely important. Similarly, In 1992, Kypros Nicolaides and his group in London looked at Down syndrome, and actually at that time, if you were over 35, you had an amniocentesis, and they actually did amniocentesis even in the first trimester in those days. And what they found was that in the women coming for amniocentesis, if the neck thickness was increased, it was more common in Down syndrome, and therefore increased nuchal translucency was a useful marker for chromosomal abnormalities. Again, at this time, there was no other screening. Very, very important. The only thing they had was age. And this is a normal nuchal translucency in the first trimester. Here's a slightly increased nuchal translucency. You can see the fetus. Look at the back of the neck. And finally, look at this fetus, and at the back of the neck, you have a greatly increased neck thickness of the space at the back of the neck, which is a positive screen. However, since then, in the evolution of screening, a lot of tests have come along, and these, until recently, this was in 2007, were the tests that were available. So we moved away from saying you're 35 and older to we are now screening you. You come with your age, and we do a number of tests: nuchal translucency, ultrasound, blood work. You come in with your a priori risk, which is your age-based risk, and now at the end of the screening, we give you another risk. Remember, this was independent of soft markers. Soft markers were introduced at a time when this screening did not exist. So these are the screening tests that were available until recently. But interestingly enough, one of the beliefs we have is that when you've had screening, your risk is low. And indeed, it may be low. But these screening tests did not pick up as much of Down syndrome as we thought. For example, if you look at the first trimester screen in the FASTER trial, it picked up 87% of babies with Down syndrome at best, which means it missed 13% of babies with Down syndrome. Furthermore, the quad screen only picked up 81%, missing 19%. And when you look at the best performance of screening with the combination of first and second trimester screening, it will pick up 95% of babies with Down syndrome, meaning that it would miss 5% of Down syndrome. This is extremely important because we very often assume that when a patient has had screening, their risk is low, and indeed it is. But first trimester screening, quad screening will miss a significant but small proportion of Down syndrome. However, a new advance came along with non-invasive testing with cell-free DNA, where it picks up 99.9% of babies with Down syndrome. Therefore, now we have a high-resolution screening test that will pick up most babies with Down syndrome. And the former paradigm where 35 or quad screen or first trimester screen was useful actually has changed quite considerably. And this is a little bit about the first paper that describes cell-free DNA. Cell-free DNA comes from the placenta, from breakdown of DNA from the placenta, which is released, and it can be detected as early as 4 weeks and rapidly disappears within a few hours of delivery. So at the same time, ultrasound advanced and many findings were found in babies with Down syndrome. And here's a list of them: increased nuchal fold thickness, absent nasal bone, fetal heart defects, brachycephaly, which is the round head, double bubble, which is consistent with duodenal atresia, short femur or humerus, urinary tract dilation, and so on. And I'm going to go through some of them because we see these very commonly and they cause a lot of distress and concern. So these are what we typically call soft markers, echogenic focus. We see this quite often: absent nasal bone, short femur and humerus, and so on. And you will very often see these in our reports. So what is a soft marker? It is a finding that occurs commonly in the general population. So it occurs with a reasonable frequency in people who are entirely normal. However, it occurs a bit more frequently amongst aneuploid fetuses. So, for example, if you're shorter than average, because people with Down syndrome are shorter on average, being shorter than average increases your risk for having Down syndrome. So when you see somebody playing for the Boston Celtics or the LA Lakers, you see that person is unlikely to have Down syndrome. However, if you go down Boylston Street or you go down to Copley and you see 500 people who are 5 feet tall, you're going to see 499 before you see one who has Down syndrome. So these tests are really poor ways of detecting Down syndrome. But I want to emphasize something really important here. This is from SMFM in 2021. And it says soft markers were initially described as a screening method for Down syndrome to improve the detection rate over that based on age-related risk alone. So soft markers were introduced in an era where age was the only thing we had. So this gives some idea of the prevalence of some of these soft markers. Echogenic focus, 3 to 5% of fetuses. If you're Asian, 30%, 1 out of 3. Choroid plexuses, 2%. Urinary tract dilation, what we call pyelectasis, 2%. Echogenic bowel, 2%. Single umbilical artery, 1%. Short femur and humerus is taken as the 5th percentile, therefore 5%. Absent nasal bone or hypoplastic nasal bone, about 0.2 to 1%. If you add this together, the screen positive rate based on soft markers alone, probably 10 to 15% of our patients will have a soft marker. So it has an extremely high false positive rate without any real benefit in terms of detection. As a matter of fact, in the days of screening before NIPT, minor ultrasound markers only increased detection by 4%, but it multiplied the false positive rate 12-fold. So this is an echogenic focus. You can see the heart beating there, and on the left, you can see that white dot in the heart, and that is an echogenic focus. Again, see the dot in the heart. That's what we call an echogenic focus. It is a normal finding. It is not a problem. It does not require any follow-up. Let's go quickly to choroid plexus cysts. Choroid plexus cysts were discovered first by our sonographer in London, Trish Chudley, in 1984 when I didn't work there at that time, but she was the lead sonographer. And later it was thought to be associated with trisomy 18. However, something very important, choroid plexus cysts do not increase the risk for Down syndrome, ever. And isolated choroid plexus cysts do not increase the risk for chromosomal abnormalities. Actually, we could have known that as far back as 1984, because this was the first paper of choroid plexus cysts published by Trish Chudley, Malcolm Pierce, and Stuart Campbell in 1984. But what did they say? This is really important. In 1984, they described 5 cases of choroid plexus cysts. And what they said was all disappeared spontaneously and 23 weeks, and normal infants were subsequently delivered. They knew this way back in 1984. So it is interesting that almost 30, 40 years later, we are worrying about something that they told us disappears and the babies were normal. And these are choroid plexus cysts. You can see those cysts in the brain. Here, if you can see my mouse, I don't know if you can, but we'll go ahead. So those are some choroid plexus cysts. Urinary tract dilation is very common. As I said, it could occur in up to 3 to 5% of babies, especially male. It's just dilation of the renal pelvis. It has no significance from the viewpoint of Down syndrome. Single umbilical artery, 1% of babies have a single umbilical artery. And as I mentioned, people and fetuses with Down syndrome are short. Therefore, their femurs and humeri are short. But being short does not give you Down syndrome. So when we tell somebody you have a short femur less than the 5th percentile, you have Down syndrome, when everything else is fine, it is highly unlikely to be so. Ventriculomegaly refers to enlargement of the ventricles, and I will come back to this in a moment because while it is associated with Down syndrome, it is not typically the finding of Down syndrome when it's isolated. This is an ultrasound of a heart. So when you have a heart defect, that is not a soft marker. And here, for those who can see the heart beating, in the middle of the heart is a hole. You can see the septum. There's a ventricular septal defect, and there's an echogenic focus. This is a complex heart defect. Here we have an absent nasal hole. So these are abnormalities that can be associated with Down syndrome but occur in normal fetuses. This is a double bubble duodenal atresia. So because there was because it was noticed that some babies with that most babies with Down syndrome had an abnormality, there was a concept of introducing what was known as genetic ultrasound. And the goal was to do an ultrasound, and if the baby looked entirely normal, you could say that the baby was unlikely to have Down syndrome, reducing their risk. And this was done for quite a while. But like I mentioned, subsequently, non-invasive testing came around. Now, trisomy 18, because it's a bigger chromosome, is associated with multiple abnormalities. So soft markers alone are useless for diagnosing trisomy 18 because fetuses with trisomy 18 have multiple abnormalities. A study by Lamiot and also by Braunstein, separate studies showed that fetuses with trisomy 18 had a minimum of 4 abnormalities and a mean of 7 to 8. So you will not miss trisomy 18 by ultrasound. 100% have clenched hands, but this needs to be done at 20 weeks or later. And this depends on a meticulous, detailed ultrasound examination at 20 weeks. And these are the clenched hands of trisomy 18. So we wrote and we were asked to write an editorial opinion in Ultrasound in Obstetrics and Gynecology about amniocentesis for trisomy 18. And we said, is second trimester genetic amniocentesis for trisomy 18 ever indicated in the presence of a normal genetic ultrasound? And here was our conclusion: do not offer amniocentesis for choroid plexus cysts. We wish to present a strong argument against this approach of routine genetic ultrasound, genetic amniocentesis following a positive serum screen for trisomy 18 or following the detection of isolated choroid plexus cysts, which was routine 2 decades ago. It is archaic and should be abandoned. So amniocentesis should not be done for choroid plexus cysts. In addition, here are the typical findings of trisomy 13. So again, these abnormalities will not be missed by ultrasound if it's done by an expert. And actually, the only one that may be missed at all is Down syndrome. So again, here's a list of the soft markers. And the ones I would like to focus on are the ones we see very commonly: the echogenic focus, the absent nasal bone, the short femur and humerus, the echogenic bowel, choroid plexus, and single umbilical artery. So let's see, what does the Society for Maternal Fetal Medicine say? We do not recommend diagnostic testing for aneuploidy, which is chromosomal abnormalities, solely for the evaluation of an isolated soft marker following a negative serum or cell-free DNA screening result. And indeed, the Society for Maternal Fetal Medicine partnered with Choosing Wisely and said 20 things physicians and patients should question. And here, number 11 is do not recommend diagnostic testing following sonographic identification of an isolated intracardiac echogenic focus or choroid plexus cyst in women with low-risk aneuploidy screening results. And last year, the Society for Maternal Fetal Medicine went again and made a detailed guideline on what to do with soft markers. For pregnant people with negative serum or cell-free DNA screening results and an isolated echogenic focus, we recommend no further evaluation, and I put that in red. This is a normal variance. They didn't say could be a normal variant. They said it is a normal variant of no clinical importance. So when you see the echogenic focus and it's isolated, it has no clinical importance. There is no indication for fetal echocardiography, follow-up ultrasound imaging, or postnatal evaluation. If at all we tell the patient anything about it, we should say it is normal. Hypoplastic nasal bone, when you have cell-free DNA, because of the high sensitivity of cell-free DNA, when you have an absent nasal bone or a hypoplastic nasal bone, they recommend no further evaluation. However, this becomes important, and it goes back to what I said before. When you have a negative serum screen and you have a hypoplastic nasal bone or absent nasal bone that is isolated, they recommend counseling because, as I mentioned, serum screening will miss 15 to 5% of babies with Down syndrome. And therefore, there is the possibility that serum screening may miss Down syndrome. And therefore, in that situation, they recommend non-invasive testing with cell-free DNA or diagnostic testing with amniocentesis, depending on clinical circumstances and patient preference. For choroid plexus cysts, we recommend no further aneuploidy evaluation, as this finding is a normal variant of no clinical importance with no indication for follow-up ultrasound imaging or postnatal evaluation. So please, when you see choroid plexus cysts, the patient does not need to come back to see whether they have disappeared. They always disappear. They are a normal variant. They have no importance whatsoever. Echogenic bowel, we recommend no further aneuploidy evaluation. However, when you see echogenic bowel, they do recommend testing for cystic fibrosis, for CMV, and follow-up ultrasounds to make sure the baby does not have a bowel problem. When you have a shortened femur or a humerus, they recommend no further evaluation. However, because a shortened femur or humerus may be associated with skeletal dysplasia or some form of dwarfism, they recommend a third trimester ultrasound to ensure that the growth is normal and that the baby does not have a skeletal dysplasia. For a single umbilical artery that is isolated, they recommend no further evaluation for aneuploidy, regardless of whether the screening was low risk or whether screening was declined, because single umbilical artery that is isolated is not associated with chromosomal abnormalities. So what do we do when we find an isolated soft marker? One, check the screening results. Make sure they were normal. If possible, order a cell-free DNA. Perform a detailed scan, and if both are normal, ignore it from the viewpoint of Down syndrome. However, as I mentioned, if it's a short femur, schedule follow-up. If it is echogenic bowel, schedule a follow-up, not for Down syndrome, but for skeletal dysplasia or for bowel issues, and make sure you test for cystic fibrosis with echogenic bowel. So we have a problem, because we continue to find these ultrasound findings. They have limited utility when you've had screening. And in today's high resolution, high sensitivity ultrasound examination, they, I would argue, are totally useless. However, the caveat is, as I have spoken about this, we are talking about isolated soft markers. When several soft markers exist together, we probably should re-evaluate it on a case-by-case basis. So if we say they are normal, why do we mention them at all? Should we mention them? And actually, I think in some ways we may be doing ourselves a disservice by having to mention them. Invasive testing should be offered to everyone, not on the basis of these findings, but because even in normal fetuses that appear normal and those with normal screening, there could be microdeletions or other chromosomal abnormalities that would not be detected by screening, that are not age dependent, and so on. So it is a policy that all patients should be told about the availability of screening. So should we mention them? Well, it's interesting that even as far back as 2009, it was noted in a survey of 67% of 1,000 SMFM specialists, only 67% reported an EIF. In other words, 33% did not. And this preceded, or was just about the time that non-invasive testing was introduced. So, quo vadis, which is a Latin word meaning where are we going, or where are you going? In the era of NIPT, isolated soft markers become irrelevant for screening for aneuploidy. Isolated. Invasive testing is not recommended for isolated soft markers. Invasive testing or NIPT should be offered if there is an absent nasal bone or if there is an increased local fold with normal serum screening, but not if NIPT is normal. However, hard markers, the heart defects, the brain abnormalities, the other abnormalities still require that the patient be informed and offered invasive testing. But these soft markers, which are normal findings, should not lead to worry of the patient, of the physician, or to us offering invasive testing. And as I have shown, the guidelines from the SMFM and from ACOG all say do not offer invasive testing for these, and for the most part do not follow up with ultrasound because these are normal findings. So the paradigm has shifted. Aneuploidy, in other words, Down syndrome, trisomy 18, trisomy 13, are no longer the major concern because almost all of them will be picked up by NIPT. However, microdeletions and other abnormalities have now assumed increased importance. And these are the ones that perhaps we should focus our testing on when patients have had negative non-invasive testing. And in closing, I gave a tribute to Beryl Benacerraf. Here I want to give a tribute to two giants in our field. The first is Stuart Campbell, who's on the left, and in all four pictures, he was my professor in London and my good colleague. In the upper left was several years ago, and in the bottom left, he is there with me about 3 weeks ago in London. He was a father of ultrasound. I would call him that. So everything we do. And on the bottom right is myself with Stuart Campbell, who's now in his 90s, and Kypros Nicolaides, who started nuchal translucency screening and a lot of the other markers. So thank you very much. Another one of my photographs from New Jersey. I think as we look at the future, we need to change our paradigm because it's important to change from the era when people were 35 and over and were offered an amniocentesis just based on age. It's also important that as we move forward, we move from the paradigm of routinely performing amniocentesis, invasive testing, and scaring women for the normal finding of a soft marker. Thank you very much. I'll be happy to take any questions or comments.
Thanks, Yinka. If anybody has questions, they can put them in the Q&A and we can address them here. Not seeing any come in yet. All right, I'm gonna go ahead and stop the recording.